Vignette, 73 years old, male, with in the past year, he frequently screams, punches, and kicks during deep sleep at night. While acting out his dreams, once a bruising in his wife's shoulder. When awakened, then become immediately alert and vividly remembers his violent action, furious dreams. Over the past 2 months, noticed a mild resting tremor in his right hand. His daily movements have become significantly slower. Okay, in the past 2 months. So the patient's sleep disorders is most closely associated with the abnormal accumulation of which of the following protein? Alpha-synuclein or tau protein or prion protein or trinucleotide repeat expansion protein. Trinucleotide repeat which is Huntington disease. Tau protein in the Alzheimer's disease. Prion protein, prion protein PRP. That is in Creutzfeldt-Jacobs disease, I think. And alpha-synuclein in what disease? I don't know. Don't remember. Parkinson or what? I think so. Anyway. Now, the patient's sleep disorder is most closely associated with abnormal accumulation of which of the following proteins? Correct answer is alpha-synuclein. Alpha-synuclein. Detailed clinical explanation. The patient exhibits REM sleep behavioral disorders co-occurring with early features of Parkinson's disease, resting tremor, bradykinesia. So pathophysiology of REM sleep behavior disorder, normal REM sleep disorders, muscle atonia paralysis mediated by brainstem nuclei subcoeruleus region. Pathophysiology of REM sleep behavioral disorders. Normal REM sleep involves muscle atonia paralysis mediated by brainstem nuclei subcoeruleus region. In RBD, which is in REM sleep behavioral disorder, degeneration of these brainstem structures disrupts motor inhibition, causing patients to physically act out violent dreams, thrashing, punching. Key diagnostic feature: patient wake up immediately, coherent, and can recall the vivid dream details. Key diagnostic features: patients wake up immediately, coherent, and can recall the vivid dream details. Okay, so this condition they call this a REM behavioral. So sleep behavioral disorders, RBD. REM sleep. Sure. Okay. So actually, this patient have a REM sleep behavioral disorders, just co-occurring with early features of Parkinson's disease. Pathological link to alpha-synuclein accumulation of misfolded insoluble alpha-synuclein forms intraneuronal inclusions known as Lewy bodies. Let's talk about Lewy bodies. Lewy bodies, alpha-synuclein. We thought about Lewy body dementia, different Alzheimer dementia, different vascular dementia, something like that. So Lewy body dementia, different with Parkinson disease. Parkinson, which is due to the dopamine. But right here they said co-occurring with early features of Parkinson disease like a resting tremor, bradykinesia. Okay, so pathological link to the alpha-synuclein accumulation of misfolded insoluble alpha-nuclein forms intraneuronal inclusions known as Lewy bodies. Degeneration begins in lower brainstem centers, causing RBD, REM sleep behavior disorder, before advancing rostrally to the substantia nigra. Now substantia nigra involved with the Parkinson. Degeneration begins in lower brainstem centers, causing RBD, before advancing rostrally to the substantia nigra, causing Parkinsonism, Parkinsonian motor size, tremor rigidity, bradykinesia. RBD is recognized as the strongest prodromal marker for synuclein neuropathies, synucleinopathy, Parkinson's disease, dementia with Lewy bodies, and multiple system atrophy. Okay. RBD is recognized as the strongest. So, RBD REM sleep behavioral disorder recognized as the strongest prodromal marker. Okay, for synucleinopathies. So the condition they call this the group of the conditions. So call this synucleinopathies are Parkinson's disease, Lewy bodies dementia or dementia with Lewy bodies, and multiple system atrophy. Keep in mind that, huh? So anything involved with the alpha nuclein, also known as synucleinopathies. So then think about Parkinson's disease, dementia with Lewy bodies, multiple system atrophy. Over 80% of patients with the idiopathic RBD convert to the synucleinopathy within 10 to 15 years. While other options are incorrect. Now, tau protein, tau which is in Alzheimer's disease, misfolded hyperphosphorylated tau aggregates into neurofibrillary tangles, which characterize Alzheimer's disease and frontotemporal dementia, tau, tauopathies. Tau pathology is not characteristically preceded by early REM sleep behavioral disorder, RBD. They say confirm very clearly here. They say tau pathology is not characteristically so preceded by early RBD. Not characterized by early RBD, REM sleep behavior disorder. Now prion proteins that are misfolded, strapes, prion proteins causes rapidly progressive neurodegenerative spongiform encephalopathies such as CJD, Creutzfeldt-Jakob disease. Creutzfeldt-Jakob disease causes rapid dementia, myoclonus, and death within months. Okay, wow, this one death within month. This prion proteins. Creutzfeldt-Jakob disease, not a mad cow disease, is that correct? I think so. I think the Creutzfeldt-Jakob disease with the prion protein, is that a mad cow disease, right? So cause rapidly dementia. Oh, this condition also cause dementia, huh? Myoclonus and death within months. Trinucleotide repeat expansion protein, which is Huntington disease. In a CAG repeat expansions in the HTT gene produce a mutant Huntington protein. In Huntington's disease, it causes psychiatric disturbances and onset typically in early adulthood, 30 to 50 years. Detailed disease treatment and management, REM sleep behavior disorders and Parkinsonism, symptomatic pharmacotherapy for REM sleep behavior disorder, first line agents, so melatonin, high dose oral melatonin, 3 to 12 milligram at bedtime, safe, well tolerated in the elderly, and restores REM atonia pathway with minimal side effects. But actually, reality, when some patient they take melatonin, they did not feel right, did not feel good. Why? They feel like the body not tolerate well, kind of like that. It disturbs the sleep and awake cycle, something like that. Okay, first line agents, melatonin, clonazepam, low dose clonazepam, 0.25 to 1 milligram at bedtime, highly effective, but used cautiously in elderly patients due to risk of morning sedation, dry, and falls, gait instability, dry, and worsening sleep apnea. Now, number two, environmental and bed partner safety modifications. Remove sharp objects, nightstands, and lamps from near the bedside. Place padded barriers or mattresses on the floor next to the bed. Recommend that bed partners temporarily sleep in separate beds or maintain a physical barrier until dreams movements are pharmacologically controlled. Number three, Management of early Parkinsonian motor symptoms. So dopaminergic therapy, they use a levodopa or carbidopa. Carbidopa, which is 25, levodopa 100 milligram TID, which is titrated based on bradykinesia and tremor functional impairment. Levodopa is the most effective drug for motor control. Levodopa. Yeah. Dopamine agonists. So, for example, like a pramipexole or ropinirole, used with caution in older adults due to risk of impulse control disorders, hallucinations, and orthostatic hypotension. MAO-B inhibitors resemble Rasagiline 1 milligram daily provides mild symptomatic relief and dopamine preservation. Okay, again about detailed treatment, detailed disease treatment and management for REM sleep, behavioral disorders, and Parkinsonism. This co-occur in early onset of Parkinsonism. Number one, which is symptomatic pharmacotherapy for REM sleep behavior disorder. What? Symptomatic pharmacotherapy for REM sleep behavioral disorders. So first line agents. So melatonin, and clonazepam. So melatonin, high dose oral melatonin 3 to 10 milligram at bedtime. This is safe and well tolerated in the elderly. Not really true. I don't think this is well tolerated in elderly. High squash Russ. Safe and well tolerated in elderly, but in reality, so when the patient take the melatonin and they get a disturbance of the sleep and awake cycles, kind of feel irritated, feel not feel good, doesn't feel good at all. I think. I mean, this is my own experience as well. Safe and well tolerated. For example, jet lag. So jet lag and we take melatonin, but Anyway, melatonin high dose oral melatonin 3 to 10 milligram at bedtime, safe, well tolerated in the elderly, and restores the REM atonia pathways with minimal side effects. Clonazepam, low dose clonazepam 0.25 to 1 milligram at bedtime, highly effective but used cautiously in elderly patients due to risk of morning sedation, false gait instability, and worsening sleep apnea. Okay, so first line agent which is melatonin or clonazepam. But when to use clonazepam, very careful because even take it at bedtime, but actually the patient still feel balatata. So risk of the morning sedation, feel morning sedation. That's why leading to false gait instability, worsening sleep apnea, etc. So that's the first line agent for symptomatic pharmacotherapy for the REM sleep behavioral disorder. Now, environmental and bed partner safety modifications. So which we need to remove all kind of sharp objects, nightstands, and lamps from near the bedside. Place padded barriers or mattresses on the floor next to the bed. Recommend that bed partners temporarily sleep in separate beds or maintain a physical barriers until dreams movements are pharmacologically controlled. Okay. Now, number three, management of early Parkinsonism. So, with the Parkinsonian motor symptoms, dopaminergic therapy. So, you carbidopa or levodopa 25, 100 milligram TID, carbidopa 25, levodopa 100. What? So titrate the based on bradykinesia and tremor functional impairment. So either carbidopa or levodopa. So levodopa is the most effective drug for motor control. Okay. Now dopamine agonist, for example, pramipexole and ropinirole, used with caution in older adults due to risk of impulse control disorders, hallucinations, and orthostatic hypotension. And now MAO-B inhibitors such as rasagiline 1 milligram daily provides a mild symptomatic relief and dopamine preservation. MAO-B inhibitors rasagiline 1 milligram daily provides a mild symptomatic relief and dopamine preservation. Okay, that's about it. Now we summary. So for this patient, a really weird thing. Number one, the patient have a REM sleep behavioral disorders. How we know that? The reason like this, the patient have a screams, punches, and kicks during deep sleep. During deep sleep, okay. Number one, and uh, number two, which is a notice about mild resting tremor. Okay, and also movement becomes significantly slower. That stands for bradykinesia, right? Also resting tremor. That's the Parkinsonism, right? So these are co-occurring. Number one, which is REM, sleep behavioral disorder, RBD, cause a yelling, screaming at nighttime, punches and kicks. Even he kicked, he punched his wife get bruised when he sleep. That's a deeply sleep deeply dead. Okay. So this condition, the patient have two things. Number one, which is RBD, which is REM sleep behavior disorder, and number two, which is Parkinsonism. Okay, signs symptoms like that. And now, if like that, if we know this is a RBD and technically RBD kind of early, so early features of Parkinson disease, they have this one. No, no, no. I mean the RBD, which is no, no. Let me say it again. RBD, REM sleep behavioral disorders. It's not. I don't think this. Let me say how I say correctly. Please wait for me. Right here now. Uh, right here, we got RBD. They say right here degeneration begins in lower brainstem centers. Okay, alpha synuclein. Uh, accumulate, that one become misfolded insoluble alpha nuclein forms. So intraneuronal inclusions known as Lewy bodies. Ah, alpha synuclein also Lewy body. So because like earlier we mentioned about they call alpha synuclein or they call this a synucleinopathies. So some condition involve like a Parkinson's, number one. Number two, which is Lewy body's dementia. And number three, which is multiple system atrophy, something like that. But the mechanism like this degeneration begins in lower brainstem centers. Got it? Causing RBD because of degeneration, lower brainstem center leading to RBD, which is REM sleep, which is deep sleep behavioral disorders, which is kicks, punches, something like that at night time. So before advancing rostrally, okay, in the lower brainstem center, then before advancing rostrally to the substantia nigra, which is to this Parkinson substantia nigra, causing Parkinsonian motor size. So then when they get into the substantia nigra, and then the patient have a motor size in the Parkinsonism, like a tremor or rigidity or bradykinesia. Got it, huh? Okay. Now, how about the detailed treatment and management in this condition? So, about symptoms. First line agent, which is melatonin. Number two, which is clonazepam. Environmental and bed partner safety modifications. So, remove the sharp objects, nightstands, and lamp away. Even partner need to sleep different bed or need to have some barrier. Need to put a mattress in the bed, kind of that, reduce, I think reduce the falling down, broken the hip, something like that. Huh? Hi, Gabriel. Yeah, yeah, okay. Hi. Now also like that, and now management of early. Now talk about beside manage about the RBD, which is REM sleep behavioral disorder. You use melatonin or clonazepam. Also need to manage about the Parkinsonism, like a tremor, something like that. Then we use dopaminergic therapy, like carbidopa and levodopa. Carbidopa 25 milligram, levodopa which is 100 milligram. TID titrated based on bradykinesia and tremor functional impairment. Levodopa is the most effective drug for motor control. Now, dopamine agonists, we use a dopamine agonist for example, pramipexole or ropinirole, used with caution in older adults due to risk of impulse control disorders. Well, for research in medicine, this you know, okay, talk about geriatrics. So use a dopamine agonist like pramiprazole or ropinirole. Use with caution in older adults due to risk of impulse control disorders. Use with caution. Risk of impulse control disorders, hallucinations, and orthostatic hypotension. This is very important. And also use a mild B inhibitors. So such as razacillin 1 milligram daily provides a mild symptomatic relief and dopamine preservation. Okay, that's about it. Thank you.